I think we're going to get started now. Thank you again, everyone, for joining us, and I hope you had a happy Halloween yesterday. My name's Annalise Sparks. I'm the Social Media and Communications Coordinator at the Joe Niekro Foundation. For those of you who aren't familiar with the foundation, we provide education, awareness, and support for those who have been affected by a brain aneurysm, AVM, and/or a hemorrhagic stroke. We have a large community of survivors and caregivers in our online support rooms, and we also have 40 support groups across the US and Canada. Today's webinar is titled AVM Treatment Options Post Aruba Trial, and our guest today is Dr. Ricardo Hanel. Dr. Hanel is the Director of Baptist Neurological Institute and Endowed Chair of Stroke and Cerebrovascular Surgery. I just want to say, Dr. Hanel, thank you so much for joining us today.
Good evening, guys. Pleasure to be here.
And before we begin, if anyone has any questions during the webinar, we'll be doing a Q&A after the presentation. So feel free to put your questions in the chat box. It should be in the lower right-hand corner. And also today's webinar will be recorded and it will be put on our YouTube channel, and I'll pop the link in there for you guys so you can watch it later. We also have our other webinars on there as well. I'm going to hand things off to Dr. Hanel, so just bear with us one moment while I switch over the presenter rights.
So thank you again, Annalise and the team at Joe Niekro for putting this together. So the idea here today is to go a little bit over what is the Aruba trial and what that change in terms of AVM treatment. And we're going to talk a little bit about what is an AVM. It's tough to say on an webinar, the level of knowledge about the topic of you guys listening and watching us there. So I'm going to go over that. That's our house in Jacksonville, and that's where we are in our beautiful, sunny, today cold Florida. It does take a village to take good care of patients and people with cerebrovascular disease, and we're very proud of this team of people. With neurologists, neurosurgeons, nurses, nurse practitioners, again, all people involved in taking good care of patients. That's our #1 priority. And I would like to say thank you again. I've been involved with Joe Niekro for many years, and I'm a big fan of the work that you guys do. It's all about awareness. We need to educate about the problem so people can understand what we're dealing with and raise the bar in treatment and care for patients with brain aneurysm, AVM, and other hemorrhagic strokes. Those are my disclosures financially. When we talk about every time I face a patient or a family with a brain arteriovenous malformation, I like to start talking about a brain AVM, where that fits. If we talk about vascular malformations in general, it's a big, broad umbrella that has many different types of pathologies inside, including the list here. So very often you see a patient sent to me to see me for a vascular malformation, and this patient has a developmental venous anomaly that is not a cause of hemorrhagic stroke. Today we're going to focus specifically in one of the 5 subtypes of vascular malformation that we call arteriovenous malformation itself, where brain AVM is a connection, a abnormal connection between high flow pipes that we call the arteries and low flow pipe, in general, one or multiple veins, where on this area of this misconnection, you have a lack of a capillary bed that typically turns the high flow, high pressure blood flow into a lower flow, low pressure situation from this resistant system that we have in our capillary network. It happens in about 0.1% of population, so 1 in 1,000. 2% of the patients have multiple AVMs, and 10% of those become symptomatic. It is the leading cause of a non-traumatic intracranial bleeding in people under 35. So this is a problem that we see fairly often in the young patients. We operate yesterday a 13-year-old young girl with a ruptured AVM. Most of these AVMs are detected under 40, but they can happen at any age. And gross features, again, we have high flow pipes going to this malformed area that is we call the nidus, and they have this outflow, typically as we call a draining vein. In general, 50% of the AVMs present with a bleeding, and in general, when we are talking about a rupture AVM, this means treatment. The talk today, I'm going to focus much more into unruptured brain AVMs, and very often we see this presenting with seizures, with a headache, or other type of phenomena like stroke because of vascular steal or pressure of this lesion in other structures of the brain. When a bleeding occurs, it can be a garden variety of flavors of bleeding depending on the part of the brain. So if the brain bleeding is on where the spinal fluid circulates, we call that subarachnoid hemorrhage. It can happen into the brain parenchyma itself. We call that intraparenchymal hemorrhage about a fourth of the time. But sometimes you can have a pure bleeding into the cavities where the spinal fluids is produced, called the ventricles. And very often you see a combination of those. Even though a bleeding from a brain AVM is not as malignant or lethal as an aneurysm, 10 to 30% of patients, depending on which series you're looking, these patients can die from this. And the annual rate of hemorrhage is anywhere between 2 to 4%, and we'll talk about that more later. If you estimate 3% per year and you happen to be 45 years old, is a table that I show all my patients with brain AVM. So if you quote them at 3% per year risk of bleeding, if this person is 35 years old and we find out about the AVM, this person is going to have a 73% risk of bleeding. If you quote a 4%, it's 83. To make it easier, we all do this calculation in the office, 105 minus the patient age. So if this person is 45, you do the math, has a 60% risk of bleeding over time. And we're going to talk about Aruba in a second and show how Aruba is very close to these numbers. So another study well done showing the same numbers. There are risk factors for AVM ruptures, and we look into this when we're talking about to treat or not to treat a brain AVM. Naturally, if this person bled before, they're higher risk. If they have presence of aneurysm, if the AVM is draining deeper. Dr. Spatzler, on his studies of measuring pressure inside AVM, he would show that the pressure on the smaller AVMs is actually higher than the pressure into larger AVMs. And if the patients have aneurysms together with the AVM, this patient is higher risk. It's not uncommon to find that patients that have AVM have also aneurysms. So about 7 to 10% of patients that have AVM, they also have aneurysms because of the high flow situation of these AVMs. If there is an aneurysm associated with an AVM, this AVM just became higher risk. You saw the number I just quoted you a second ago, 3 to 4%. If you have an aneurysm there, then this risk goes to about 7 to 8%. And if this aneurysm is inside the AVM, it goes up to 10%. So aneurysms have everything to do with increasing the risk of rupture of an AVM if this AVM never bled. When we're dealing with the aneurysm AVM a complex situation, we typically treat the symptomatic one first, and not uncommon to deal with the aneurysm first because of the higher risk of bleeding of that. When we're talking about decision to treat, the first rule of medicine applies deeply to AVM. The first rule is do no harm. You have to analyze patient by patient, case by case with the guidelines and principles that I'll show you here. It doesn't mean that we don't follow a thought process behind when I say case by case, but all the studies that we have, they will serve as a base to individualized care. So every person is different a little bit, and what are their perspectives. So for example, if I'm treating an 18-year-old professional musician where her right hand is extremely important to her profession, I would have a different level of acceptance for any type of loss of dexterity on that hand. If this person is a 45-year-old guy that is farmer, that maybe define motor skill, dexterity is not as important for him. Not that it's not important. I hope you understand what I mean. But it's very important to put things in perspective, and it's not uncommon to see an AVM. I saw another young girl, 4-year-old, found out a very large AVM after having a head trauma. She was playing in the playground, hit her head, got a CAT scan. She has a large AVM. Any treatment for her would be higher risk than the disease by itself. So on that one, counseling is the way to go, and need to make people aware. Each one of these situations that you see here on the screen, they're different, and they deserve special attention. I have no question in my mind, and we are dealing with a brain AVM. These patients belong to centers that can provide at a very high frequency all these types of treatments, where we can get the AVM out of the head with open surgery under operating microscope that we call microneurosurgery, radiation therapy with proton radiation like we have here in Jacksonville, gamma knife, and LINAC is a different type of radiation. We have all three available here. Embolization, combination of the approach of all the above, or just waiting. Sometimes doing nothing is the best for the patient. Sometimes it's the hardest to convince patient and family that the best option is to leave that alone. We use this classification that was published by Dr. Spatzer. It's hard for you to see here at the base, but this is an old classification that takes in consideration the size of the AVM, with points for each one of that. 1 point if the AVM is under 3, 2 points if the AVM is 3 to 6, 3 points if the AVM is 6 and above. If it's on an eloquent area of the brain, meaning area of the brain that moves the arm or the leg, we call the motor area. Area of the brain that is related to speech, comprehension, or expression is another area. And if this AVM has drainage to the deeper structures of the brain. So a combination of these is going to give us AVMs from grade 1 to grade 5. And the decision is case by case. We have general guidelines that I'll share with you guys here in a second. In general, open neurosurgery, even though that is the apparent most invasive, is also the most effective in terms that once the AVM is resected, the risk of that AVM bleeding is essentially eliminated. No question, there are risks related to the size, location of that AVM. And this is the original paper published by Dr. Spatzler, where he looked at his series of small AVMs, not in eloquent brain, or small AVMs in eloquent brain, or AVMs 3 to 6 centimeters, so grade 1 or 2, that later Dr. Spatzler modified. Sorry for the misspelling here, my former boss name, he would be mad at me. You would see here that if you have a small AVM, in general, the results with surgery are excellent, under 5% complication rate with a 99.9% cure rate. When you get to group 3 or group B, things start getting a little more complicated. When you go to groups 4 and 5, grade 4 and 5, then you start talking about significant post-operative complications. Radiosurgery is very well studied, is non-invasive. Non-invasive does not mean risk-free. There is a size correlation. The smaller the nidus, the higher the odds of occluding these AVMs with radiation. Embolization is the least studied modality, and we're going to talk about that in a second when we talk about Aruba. If you look at the cure rates, surgery or microsurgery is number 1, radiosurgery is number 2, and embolization is number 3. And embolization can also be related to complications. So when you're talking about treatment, you have to put all these 3 together and consider what to do for every single AVM. An AVM that is not a good candidate for open surgery may be good for embolization. So you mix and matching these 3 with expertise, that's what leads to best results. Teamwork, get all the tools available to offer the best treatment for this patient, and complication avoidance. You gotta know what you're dealing with. If you don't have much experience what you're dealing with, you will end up misreading situations and leading to complications like this poor little dog end up getting in a fight with a porcupine and say that the dog got a complication here. This is illustration for you guys, grades of AVMs by Dr. Spatzer, published in 1986, Journal of Neurosurgery. So a small AVM, non-eloquent cortex, that's a Spatzler-Martin grade 1. There are 3 ways to get a grade 2, and you see here the combinations of that. Size, 2 points, or deep venous drainage and size, 2 points, or size and eloquence, 2 points. Those 2, grade 1 and grade 2, are very good surgical cases. In general, guidelines at our place, if a patient is a good candidate for surgery, we typically recommend surgery. Why? Cure rate very close to 100%. We keep radiosurgery and embolization for second line for patients that are not good microsurgery candidates, or patients that have a strong preference against craniotomy for whatever reason, and natural patient preference plays a role on this. You got to remember, radiosurgery cure rates are not as good as microsurgery, and even though it's minimally invasive, there's no opening of the skull. We can see radiation-induced problems that can be fairly dramatic, and then most of the time resolve with treatment, but sometimes they don't. We save embolization for specific situations that we can achieve a cure. And this is a 21-year-old, just to illustrate for you guys, 21-year-old guy presenting with seizures. This is his AVM. So you see a picture here through his face. This is from the side of his face. We decided to do embolization, and we did embolization to decrease the flow in the AVM, took him immediately to the operating room. This is an open of his skull. This is his AVM. We have these advanced tools that we can inject contrast into the microscope that give us a nice picture during the surgery. And once the surgery is done, we can do during the surgery what we call intraoperative angiogram to prove that this AVM is totally gone during surgery. I forgot to show you here, this young gentleman also had an aneurysm that is seen right here at the bottom of this picture. So during surgery, we took care of both problems. We clipped his aneurysm and we took care of the AVM, and 6 months later, he is completely back to normal life. This older lady, she's 45, she had a bleeding that was operated elsewhere here in Jacksonville. They didn't realize she had this AVM here. And when she came to us, this is her picture of this small AVM. And she had already been through a lot with the previous operation. She would like to avoid another open surgery. So we came through the catheter via microcatheter approach. We embolize her AVM. So with a single shot of this embolic agent that looks like lava called onyx, we fix her AVM. When you get to group 3 or grade 3, to be more precise, then it becomes more complex because you're talking about bigger AVMs and very often in eloquent cortex. This is a rare bird to find. There is a grade 3 just because of size. Very often you're dealing with grade 3 because there is an eloquent cortex involved, and the decision making is much more individualized. This is just an example. If you have a grade 3 because of 2 for size, 1 for eloquence, like this 14-year-old, we operate on this child. Functional MRI confirming that the lesion is just behind the area of the brain that moves his arm, and this is the picture of his angiogram. We do this advanced imaging that we can literally image the bundles of fibers of motor and sensitive fibers that is going away into his brain, and we motor mapping his area, and we operate on that and remove that. There's another grade 3 in a different scenario. This lady has a problem that she's has obesity. She's about 300 pounds, not a good patient for an open surgery from general anesthesia perspective, and she has this AVM here sitting what we call the cerebellum. So there's a picture through the face There's a picture through the ear, so AP and lateral as we call. And here you see the pictures of that. And on her case, we end up treating her just with embolization. So in grade 1 and 2 AVM, surgery, first line, grade 3, combination of approaches. In this case, she got embolization and cured by embolization. When you get to AVMs that never rupture on grade 4 and 5, then observation is #1 therapy, unless we have somebody with disabling seizures or hemorrhages. If this person is unruptured, very often we spend a lot of time counseling this person to do not get treated for the AVM, because the risk of complication now goes to 20–30%. We do treat high-risk features. So let's say this person has an aneurysm associated with that. Remember, I told you aneurysm will make this higher risk, so we can target aneurysm and decrease the risk of bleeding with that. This is again Dr. Spatzler work, where I trained at the Barrow, showing that if you leave these AVMs alone, the risk of hemorrhage is better than if you try to treat these lesions or if you treat them just partially. So those are the situations that we treat and indicate treatment for a grade 4 and 5 AVM. If they have aneurysms there, if this person is going through a progression of symptoms, and we are on the midst of discussing treatment with another young lady that has left side paralysis that is getting worse, and we don't have much to offer her, but that's when we consider treating that. The Aruba trial was a very, very well-designed study by Dr. Moore, and anything that we will say here is a criticism on the next 10 minutes to the Aruba is just a fact that we need to learn more, and the study was by no means perfect, but I think we have to be generous and thankful to people like Dr. Moore that put a lot of effort to get this together. His attempt was to try to get an answer if patients with AVMs that never bled should be treated or not. And he randomized these patients to no treatment versus any treatment modality, any size, any grade, any combination of the treatments. And that's where we start seeing problems. Arteriovenous malformations of the brain are probably one of the most heterogeneous, unique situations that we deal with as neurosurgeons. So to do a trial where we put all these cats on the same bag, I think is too ambitious and maybe was not the best model for that. They define outcomes to be measured as death or symptomatic stroke at endpoints up to 5 years, and secondary endpoints of any impairment at more than a modified ranking scale, that is a functional scale. If this person is not independent, that would be called clinical impairment. The idea was to do this for a large number of patients in 100 and some sites, and this was way slower than we expected at the beginning of the study, and end up stopping the study because of an interim analysis in 2013. So over 6 years, 226 patients were enrolled, 110 allocated to medical treatment, 116 allocated to treatment, with 114 included on the analysis. Over 1,700 patients were screened, only 220 were enrolled, and the study was stopped because on the no treatment arm, just observation, there was a 10% event rate at 33 months, but there was a 30% event rate at the interventional arm. And because of that, this was considered not to be safe, and this study was stopped. When you look at the type of the AVMs treated on Aruba or enrolled in Aruba, you're going to see that most of the time, 68% of these AVMs were low-grade AVMs. So I just showed you Dr. Spatzler's number, and our series is very similar. Our complication rate for these two groups, grade 1, grade 2 Spatzler AVMs, are in general under 5%. So you see the numbers that I'll show you here in a second, that the complication rate for these AVMs was much higher than we see in our clinical practice. You see here there were AVMs that are large, so you see here that you have 7% in one arm and 14% on the other arm, the medical arm of grade 4 AVMs. But in general, the majority of these patients were grade 1 and 2 on the treatment arm and 55% on the medical arm. And you see here other data with that. Again, this is what we call Kaplan-Meier survival free of event. And you see here that if you go through medical management, you have a lower chance of having problems on Aruba than if you are treated. So you see again this 10% on the medical management versus 30%. And again, this is another analysis of that, and that just table just showing that bigger. But you see here, and I think that's very important, we learned this from Aruba, at 33-month analysis, 5.5%, so 33 months, a little under 3 years. So you see here that this number is above 2% risk of bleeding and above around 1%. So if you put stroke, ischemic, and hemorrhagic in patients that did not get treatment, you see that this is about a 3% per year, very close to that number that we use for table calculations there. But you see here that you have a lot of trouble with creating bleedings with treatment for AVM. And this has a lot to do with the way embolization was used on the trials. So I think it's very fair to say that we learned with Aruba that the way embolization was used on the treatment of these AVMs, it created a significant amount of hemorrhagic complication. And we don't use embolization as a first-line treatment modality for these patients, especially if you're talking about Spatzler-Martin grade 1 and 2. You see here, I showed you that on the treatment arm, 68% of these patients had grade 1 or grade 2 AVM. Only 5 of these patients were treated with surgery alone, where in many centers in the United States and Europe and Brazil and Australia, surgery would be first-line treatment. You see here on the sites involved on the Aruba, embolization was first-line treatment for a lot of these treatments. You see here 58 patients that underwent embolization alone on 30 or combined with surgery, radiosurgery, or both in many others. And here you see the complication rate. You see here for Spatzler-Martin grade 2, a 34% complication rate that is way too high in our opinion, and that is a source of criticism for the Aruba study. Again, very nicely done study, showed us the natural history for AVM. AVMs are not benign lesions, 3.7% per year event rate for patients with AVM, and a 2.2% hemorrhagic rate for this. Another thing that was not considered in Aruba, and we pay attention, this is a Mike Lawton, UCSF, Guo et al. Published that, UCSF. When we're dealing with an AVM that never bled, we look for hints on an MRI that this AVM may bled before without symptoms, and we look at the silent microhemorrhages, and here it is well demonstrated if these people had silent microhemorrhage, they behave much more like a rupture AVM, and we pay attention to that. Again, for sake of time, I'm going to skip a little bit through this, but another criticism is, and this is an issue of funding, when you start a study of this magnitude, you don't have money to follow all these patients, but 1,700 patients were screened, only 226 were followed. Unfortunately, because of money, they could not follow every single patient. Ideally, originally, this was the idea initially was to enroll 104 centers to be enrolling patients. Only 39 participate, and a lot of them only enrolled one patient. So 29 centers enrolled more than one patient, but 10 of them enrolled just one, meaning that maybe the experience on the sites was not up to par. Again, we talk about this briefly, about treatment, utilize, embolization, radiation, and surgery. Again, if you look at all these publications, some of ours included, you see that surgery for low-grade AVM remains number one line of treatment. And you're going to look at the Toronto experience here. You see here patients with permanent deficits on grade 1 and grade 2 Aruba-like patients with a permanent deficit of 3.4%, very far from that 30% Aruba number. And you look at the UCSF here, Michael Lawton experience on Aruba-like patients. You're going to see here their results. You see here 61 patients with Aruba-like, most of them treated with surgery. You see here that the complication rate was much lower, less than half what Aruba showed for their patients. Another problem with Aruba, we stopped too soon. We know that if you're curing an AVM, you're eliminating the risk of rupture. That's why you treat an unruptured brain AVM. 3 years does not reflect much in the life of a 20-year-old that got surgery or treatment for an AVM. So when we talk about AVM, these curves may cross down the line. If you're talking about young patients, 3 years is not enough for follow-up. What I think I learned from Aruba, I think we need longer follow-up. I think we need to be very specific about which lesions we're talking about, and we think we need to put a guideline for the sites that are doing, and we need to get sites that have the same philosophy in treating these patients. Then we can compare. I'm working with Mike Lawton trying to get funding for a study focusing specifically on grade 1, grade 2 AVM, enrolling patients in 10, 15 sites all over the United States, Canada, and the rest of the world, focusing in sites that have a similar philosophy. If surgery can be done safely, meaning complication rates under 5%, we will use surgery as first line, using embolization and radiation for those patients where that cannot be accomplished. And we hope that we can get funded. We'll be submitting a grant to Joe Nicro and other foundations. Unfortunately, there was no interest from our NIH to fund this study, but we're hoping we can get funded in the future. I think Aruba is a starting point. We need to get a better understanding of the complication rate and what we're exposing patients to. Brain AVMs are by no means a homogeneous entity. Very, very unique lesion. Every patient is different. A single randomized controlled trial cannot give us the answer. It made me very aware, as all of us, that we need to better assess our treatment options and truly measure this in each one of the AVM situations. I think AVMs are not necessarily benign. It's all about measuring the risk of treatment versus the natural history of the disease and individualize this to every single patient that comes through our door. AVMs have to be done in a high volume comprehensive center. If you're doing 2 a year, maybe you should not be doing. And I think for the patients, and Joe Nicro does a very good job in raising awareness of that. It's not bad publicity about Dr. A, Center A versus Center B. You will be better treated in a place that these people have more experience and they're used to deal with this disease. And we do need better studies to assess specific treatment modalities. And with that, I'll stop talking, guys. And again, this should be a forum of discussion, of questions and answers. Because I was looking at my screen, I don't know which questions came around. So I'm going to exit my screen so I can see the chat and see if there is any questions from any of you there. And I'll be glad to answer anything. Annalise, if you have any questions there that the group put to me, I'll be glad to answer. If not, we can come with talking points in the next 10, 15 minutes. We can discuss anything that you guys may want to hear, may want to talk about.
Yes, thank you so much, Dr. Hanel, for that presentation. It was super interesting. I actually have some comments and questions myself.
Absolutely.
So it's more common for an AVM without an aneurysm than to have both present?
Yes, correct.
Okay. And through the Aruba trial, you determine, well, embolization is not the best treatment option, is what you concluded.
Yeah, so we have to be very careful to make statements because all these modalities, they are volume dependent, meaning it depends how much the site that you're seeing as a patient. If you're seeing a doctor in Limoges, France, is different than seeing a doctor in uh, I'm going to pick a city that I know there's nobody doing AVM intervention, in Brunswick, Georgia. Uh, Limoges has a center with a very high level AVM embolization. Brunswick, Georgia has nobody. So it's very, very location specific. And as a patient, uh, you have to be very aware that depending where you're going, the odds of you getting treatment A versus treatment B change. And that's probably prudent because every place develop their niche treatment one way or the other. So going back to your first point, and I'll go back to the treatment, aneurysms happen in about 10-15% of patients with AVM. That's the number. So most of the AVMs don't have aneurysms.
Okay.
In terms of treatment, the best situation for a patient is to go to a place that has all modalities available and they can mix and match in general guidelines for a Spatzler Martin grade 1 or grade 2, we would do surgery without embolization. But for example, in some Spatzler Martin grade 1 and 2 AVMs, I'll see a feeding vessel that will make my surgery harder. That is a deeper feeding vessel, or is a feeding vessel that is hidden behind a structure of the brain. On those situations, because I have all tools available, I can say, I'm going to do an embolization before surgery with a specific reason to go after this specific target. Or sometimes we can have situations like one of our patients that is, she's a phenomenal Joe Nicro supporter. She has a very small AVM that has just a single artery feeding this AVM. I know if I go to that artery and I shut down that artery endonitis with onyx or glue, that's cure for AVM. So this is a very specific situation where, yes, we could do open surgery and go take that AVM, but I discussed with the patient. On her case, I called her, you have a 50-60% chance that we can fix the whole AVM just with embolization. So that first line treatment, what comes first? That's why I say you have to mix and match the tools to individualize the care for that specific patient. Is in general, surgery for low-grade AVMs is first option. And endovascular, what you have to be very careful, and I think that's the lesson that I learned from Aruba, and I can speak for myself, is that if you try to be too aggressive because of the misleading idea that endovascular is minimally invasive, I think this should be about low risk or high risk. In terms of invasion, that is very, very questionable. If you do an embolization and this patient bleeds, so you have a 30% hemorrhagic complication in Aruba, 20% hemorrhagic complication in Aruba, that's a very high number. So that lesson I think is pretty clear. If you're not prudent, if you're not cautious, and you have a specific strategy to use embolization can lead to complications. So you have to be very, very aware of that. And I think we learned that the way endovascular embolization was used at Aruba, it showed that it was not better than the disease by itself. So I think that's a lesson there that we learned from Aruba.
Okay, thank you for further clarifying that. Just in the beginning of the presentation, you brought up that chart that showed that the risk of a bleed decreases with the increase of age. Is that correct?
Yes, correct. So do you have my screen there?
Yes.
So I'm going to go back to that because I think that's a very important. So when I'm seeing somebody in the office with a, I'm going to do quicker here. Here. When I'm seeing somebody in the office, uh, I pull this chart and I show patients this chart. So if I'm seeing a 35-year-old young female, or if I'm seeing a 75-year-old gentleman, so this guy that comes to my mind, he's 75 years old. He has a very large aneurysm associated with his small AVM. So I show him this, and to treat this AVM, he probably has anywhere between 10 and 15% complication rate because this is sitting right on his area that moves his right arm. So the aneurysm, my risk complication for his treatment of the aneurysm is under 1%, or under 1% for major complication, 2% for other complications, so under 3%. So I treat his aneurysm and we decide to leave the AVM alone. He's 75. If I look here at his risk of bleeding, it's about 30%. If he lives, so you see here his lifetime per year, that's 3%. So another table that I always pull out there is an actuarial table. If the 75-year-old guy goes to any of these websites and get his age estimation for American gentlemen, for the male population, that number is about 85, 87. So he'll have a risk of a 2-3%. So you see this in the next 10 years of about a 30%. This number is very different than that 35-year-old that is going to live much longer. So we use these numbers to be more conservative. The older the patient, the more conservative we are in terms of indicating treatment for these lesions. I think that's the bottom line of this table. The older we are, the more conservative we are with indicating treatment. Okay. Another thing is the potential for recovery of the older population is decreased compared to the potential of recovery for the youngsters. The younger the patient, the more plasticity we have on the brain, and these patients typically recover much more in terms of a problem perioperative or post-operative than a 75, 80-year-old. So we use this just to illustrate that the younger the patient, the higher risk for bleeding. The older the patient, the lower the risk for bleeding. It's a direct consequence of how many years these patients are going to live.
Okay, great. Yeah, that was my question. I was just curious how the treatment options change when they get older. Do you not suggest, messing with the AVM and things like that? But
correct, and that's what I said, Annalise. I think this is very individualized.
Yes.
Again, I keep giving you real examples that come to my mind when I talk about AVM, and those are patients that we deal with at a weekly basis. And when you have to counsel that, because you have a tool or 3 tools to treat AVMs, it doesn't mean that you should be treating on this sense. I think counseling is part of treatment, and I think it's a very important part of treatment. Sometimes it's harder to convince a patient, like this 4-year-old girl that I told you about. I am a father of 4 kids. I can put myself on those parents' shoes. It's very hard to look at your 4-year-old beautiful young daughter and decide we're not going to do anything about this. Mm-hmm. It doesn't mean you're not doing anything. You're doing what is the best thing for the child, that is not touch the AVM. Because if you touch the AVM, the odds of curing that very large AVM is low. The odds of hurting her on the process of trying to cure that AVM is high. So it's a matter of talking to the patients and talking to the parents about, what, best decision for your care is leave this alone. Do I have a risk of this bleeding in my head, doctor? Yes, you do. But your best odds is by leaving this alone. So sometimes counseling them to leave it alone is the right thing to do for these AVMs.
Okay, thank you for explaining that. We have a couple of questions that came in. One is, what percentage of AVMs are not treatable? That's
a very good question. So again, this has to be a case-by-case decision. It's very hard to say 10, 20, 30%. Most of the AVMs, and you see here, I'll show you that table from the Spatzler-Martin paper. So you see here an idea of AVM treatment. You look at the numbers from the 1986 Spatzler-Martin series, you see that 120 patients had grade 1 to grade 3 and only 20. So we're probably talking about 1 in 4, 1 in 5, they'll be big enough that we wouldn't recommend treatment. But again, this is a broad spectrum of lesions, and the decision to treat is case by case and is also based on expectation. I'll give you another example. Grade 3 AVM sitting right on the motor strip of this 18-year-old first year of college student. She happened to have an aneurysm associated with that. We treat the aneurysm and we decide it's not that her AVM is not treatable. We intentionally and very, very high level discussion with the mother and the patient decide not to treat the AVM. She's going through college, she's right-handed, the treatment, surgery or radiosurgery could leave her with trouble using her right hand. She said, know what? I'm gonna live with this. I'm gonna go through college, see how that goes, and I might change my mind and decide to be treated, but for now, I'm just gonna watch that. So treatable is how much risk are you willing to accept as a patient or as a family for complications that can be, that are totally related to the place, location of the AVM. What is your risk acceptance for treatment? So the concept of treatable or not treatable, it depends on how much risk are you willing to accept for treatment. And that's what it can change those situations. A bleeding changes a lot of things. So we have a patient that we decide to watch. She's 40. She was 42 when this happened. She bled on the AVM, and the bleeding gave her a problem. So now I have to go out, take the clot, and the clot sitting right next to the AVM. So the cat is out of the bag from the sense that the disease already create a problem for her, and we end up fixing the AVM together with that. So treatable, no treatable is a very, very relative concept. Depends a lot on the patient, risk acceptance or tolerance, and bleeding or no bleeding. So that's a moving target.
Yes, yeah, absolutely. That makes sense. Um, so a bit of a long question, but so if you had a 12-year-old boy with a grade 4 AVM with already a loss of peripheral vision in both eyes, and he had already a spontaneous bleed a year before with no residual deficits and no treatment, what, if any, treatments would you recommend?
Yeah, so that's a great question, and I was sure expecting that I would hear that from you guys. I think this is a case that needs to be very well studied in a center that has high experience, because this young gentleman deserves an MRI of the brain, and he deserves a highly selective cerebral angiogram looking for high risk features. Very often on these, when we have a bleeding on a grade 4 AVM, you can identify where the AVM bled from and target that with treatment, with embolization or with radiation. In general, for rupture AVMs like this 12-year-old boy that we're talking about, in general, radiation is a second line treatment for those, because the radiation takes time. And in a Spatzler-Martin grade 4, we're probably talking about a very large lesion that is not amenable for radiation in a single session. But that's exactly the type of patient that benefits. And if you are the mother of this 12-year-old with us on the webinar, or the father or family member, this person needs to go. And Annalise has my number, has my contact. And if you are regardless where you are in the country, you can reach out to Annalise, and I've done this with John Nicro many times before. If you want to come to Jacksonville, naturally, you're most welcome to come and see us here. But if you are in California, I can guide you to the place to go in California. I know people all over the country, all over the world that are experts in AVM, but this young boy deserves to be seen by a high-level expert or group of experts to see if there's anything that can be done with acceptable risk to decrease the risk of him bleeding again. And grade 4 AVMs, let's say this 12-year-old boy never had a bleeding and has no symptoms. This young boy, unless he has a high-risk aneurysm identified on the angiogram or any super high-risk feature like an aneurysm, would probably decide, I would probably counsel not to treat. But he has a bleeding and he has trouble with his vision, so the AVM is symptomatic. I would consider treatment, and I would get him seen in a high volume, high experience center. And I'll be glad to help you if you need any help. And Joe Nicker does a phenomenal job, and we work with Melissa, Natalie, and the Joe Nicker team, helping people where to go to get seen and to get expert opinions and expert care on the best interest of this person.
Thank you so much for explaining all of that. And I sent my email to this person, so if they want additional follow-up, feel free to reach out to me via email. So I'll take one or two more questions. Someone asked, can a bleed itself obliterate an AVM?
Yeah, that's a great question. Yes, it can. So in general, for patients under 45 years old, if you see a specific pattern of brain bleeding, like an intraparenchymal hemorrhage, we are typically suspicious, especially if the bleeding is not related to a high blood pressure event. We have a high index of suspicion to think about there's an AVM hidden. And sometimes the first time we do an angiogram, we don't see an AVM, so the AVM is compressed, is squeezed by the blood clot, and you go back in 3 months and check again, and there is an AVM there. I have no question that some of these small AVMs can be compressed and thrombosed, disappear because of the clot. But in general, in these patients that we have this type of picture of these blood clots into the brain, intraparenchymal hemorrhage, we do repeat angiogram at least twice, once with the fresh blood clot and once the clot disappears, to make sure that we don't have a high-risk AVM showing up after the clot is absorbed. So once the clot goes away, the clot that was squeezing the AVM, the clot goes away, the AVM can also reopen.
Okay, thank you very much, Dr. Hanel. Sorry, I'm just reading some of these questions. We had a couple questions on gamma knife radiation. So do you have any thoughts on that in terms of treating AVMs?
I think radiosurgery, gamma knife is one of the flavors of radiation. They use gamma rays. You can do this with X rays, and you can do this with proton beams. I think it's a very important tool on the treatment of brain AVMs. It's a case by case, but there's no question radiosurgery is a phenomenal tool, very important on the treatment of brain AVMs. We serve radiosurgery, we reserve radiosurgery in our center to AVMs that are in deep-seated locations, AVMs that are amenable for surgery on the broad term of the term, but the patient is not a good candidate for general anesthesia patient. So we do use radiosurgery very often as an important tool for treatment of brain AVMs. Again, it's a case-by-case discussion, which tool comes ahead of the other, and it's about patient preference and patient expectation.
Okay, great. Thank you so much. And
I want to make one more comment there, Annelise. I think it's important from the patient perspective. You always got to be careful in everything that you hear about treatments. Oh, minimally invasive surgery, no incision. All treatments have their own inherent risks. So all treatment with open head or through the groin or radiation, they all have risks. So when you're talking with a professional that is helping with that, you got to always be very, very specific. What are the risks of the treatment? None of these treatments are risk-free. So you got to be very aware what you're buying to when you decide for a treatment modality versus another.
Right. Absolutely. Yes. Okay, we're coming up on the hour, so I'm just going to take one more question, if you don't mind, Dr. Hanel.
No,
Uh,
I'm here for you.
Someone asked, what studies have been done, or do you think there should be done for unruptured AVMs, but that have been treated prior without obliteration?
So I think it's very important to put studies that are very specific. I think this person that asked us the question, thank you for all your questions. Uh, I think we have to create studies that are very specific. So for example, Spatzler, Martin, grade 1, grade 2, previously treated with embolization. So I'm sure there will be a number of patients all over the world with that situation. I think we should do a study. What is the best option for these patients? I think the more specific we are with the question, the better the quality of the answer, because then you can say, okay, for this problem that we just talked about, that is the best answer. So you have to. I think the one that we are working now, and I'm working again with Michael Lawton on that. Michael is a giant on the field on this topic. Uh, we firmly believe that for low-grade AVM, surgery is first-line treatment and does patients a very good service with a low risk of complication in the right hands. So we are working getting funding uh, to do this study. That's the next one coming down the line. But I think this should be done for other modalities too. So again, we are doing surgery as first line, but I think centers that do a lot of radiation uh, need to get together, and we are working with a different group on that for embolization, for example, as a first-line treatment for very specific lesions that could be cured at a high rate with embolization. So those are my thoughts about studies. But there's no question that we need better and we need more studies on the specific treatments of brain AVM.
Okay, great. Thank you so much, Dr. Hanel. And I just want to say thank you again for doing this presentation. It was super beneficial. I hope everyone enjoyed the presentation. Um, and thank you everyone for joining us. This webinar was recorded, so it will be on our YouTube channel. And thank you again, Dr. Hanel. This was super informative.
Thank you, guys. Appreciate it.
Thank you so much, guys.
Have a good one.
Have a good night.